Hi everyone, welcome to this overview of dental radiography. So today we are going to be talking about the different applications of dental radiography, and we'll also be looking at a little bit of dental anatomy, the equipment that we use, briefly the patient care issues that you might come across, and radiation protection. Okay, so first thing is the application. So why do we use radiography in dentistry? So pretty much all of you probably have had a dental x-ray at some point. You go to the dentist, they think you might have a filling or whatever it might be, and they will give you an x-ray of your teeth. So it shows any cavities, but it also can help show any maybe cancerous masses or benign masses that might be within the mouth. People might have hidden wisdom teeth that are causing them issues. People might have sort of temporomandibular issues like TMJ, or they might have some necrosis of the bone for whatever reason. People also might have dental radiography because they're about to start chemotherapy and they have to make sure that their mouth is healthy before the immune system gets weakened. So there's lots of different reasons. Obviously it can be used when someone is getting dental work done, so braces or whatever it might be. They can use dental radiography just to check that progression of the treatment. One of the reasons that you might see it getting done when you're out on placement and when you qualify, maybe in the middle of the night, you'll get a bleep or whatever it is, and you've got a patient who has had some sort of trauma and they might need images of their mouth. It can also show infection. Obviously, infection, can really turn quite serious quite quickly. So if someone has an abscess in their mouth or an infection in their gums or whatever it might be, dental radiography can help show that. And then people who are going in for treatment that's a little bit more serious, so like an actual operation of the jaw or the mouth or the teeth, they can have x-rays pre and post that. The type of x-rays that we tend to do when we're talking about dentistry would be an OPG, so sometimes known as a pantomography or a pantogram or an orthopantogram, but we just call it an OPG because that's easier. So that is the two-dimensional view that we get from ear to ear. So it looks like you're smiling, but you shouldn't look like you're smiling too much or it's positioned wrongly. We'll talk about that a little bit further on. And it uses a panoramic x-ray, so it's basically moving all the way around. Again, we'll look at that in a little bit more detail. We also, you might have noticed when you go to the dentist that you have intraoral radiography, and that's when you put in the image receptor inside the mouth. So there's two different types that are most commonly used. One is the Bitewing, we'll talk about that in a wee second, and one is the Periapical, but we'll look at them both in a little bit more detail. I suppose it's important to say that it might be the case that you don't get to attend the dental hospital this year. I'll keep you updated, but for the moment, you're not attending unless you have heard differently from me. So this is the 9th of August. So at the moment, from the 9th of August, you're not attending, and that's just because obviously in the dental hospital, they have been using aerosol generated procedures, so they had to be super, super strict when it came to COVID. That meant there was a massive backlog of dentistry students and oral health science students. And I think actually maybe some dentistry students had to repeat a whole year, so they've not had any capacity for students for radiography. So that'll be the case unless you hear otherwise from myself or any of the other module team. So hopefully this, because you're not getting to go to the dental hospital, hopefully this will give you a wee bit of an overview of some of the things that you might do. And obviously you don't just do these things, especially OPGs, you do them out in normal practice. It's not just something that they do in the dental hospital. Okay, so moving on to the Bitewing technique. So yeah, some of you might have had this done. I've had it done. You'll be lying in the dentist chair, and you place in the image receptor into your mouth, okay? And it's parallel to the crowns of both your upper and your lower teeth. And it has to be stabilized essentially by you biting or the patient biting onto this little sort of holder, essentially, central to where your teeth meet. And then there's a 10-degree cranial, so to the head angulation of the tube, and that is the position for the Bitewing technique. And what that's going to show is a crown, the crowns of both, the crowns of teeth of both jaws. So you're going to see upper and lower teeth in that image. So that's going to be an example of a bite wing. So you can see obviously this patient's got multiple fillings. So you can see the white bits are the fillings. Okay. And you can see both upper and lower, and you can see that this is actually the little bite wing holder that the patient is bit down onto. So that's the Bitewing technique. So the periapical technique is slightly different. So the image receptor is put in the mouth and it's parallel to the long axis of the tooth. So you can see in the image here, I wonder if I can point on this. I don't think I can, but if maybe you can see, I'm not sure. But the long axis of the tooth is here. The image receptor is just over here on the left, and it's running parallel to the long axis of the tooth. And then you can see where it says CR, this is the central beam or the central ray, and that's at 90 degrees, so it's perpendicular to the long axis of the tooth. So just like what we do with normal x-rays of, bones, we want to have a view that is perpendicular to the image receptor. And again, they use a holder just to stabilize the image receptor as well. And what that's going to show us is it'll show the tooth that's in question, but it'll also show the roots. Okay, so it's really good to look and see if there's any issues with the root of the tooth as opposed to just the main crown of the tooth. So you can see here, this is a periapical view, and you can see how much it shows of the tooth. So it's going right in, you can see the nerve coming down, and it's going right into the roots, down into the gum and the bone. So it's giving a really, really good image, a full image of the full tooth. But obviously if you compare it to the bite wing, you don't have the tooth above. So it's just purely for the one that's in question. Okay, so in terms of anatomy of your tooth, this is something that you can go over and learn in your own time, but we'll just talk briefly. So obviously you have the dentin, and then number 2 up here, you've got the enamel, so the nice hard bit, and then you've got the pulp, and then you can work your way down and learn this. So down here at the bottom, just right at the bottom of the root, you've got the foramen. 5, you've got the root canal. Anyone that's ever had treatment knows about that. There's lots of different things that you should learn and go through this image yourself, and just be aware of this image, that you can label the anatomy of the tooth on the periapical view. So, as we said, what is intraoral good for? So what is intraoral radiography good for? Sort of went over this in the beginning, but it's good for any sort of caries detection. It's good for any periapical pathology. So again, could potentially be a mass or a lesion that could be malignant or benign. It's good for any periodontal lesions. And sometimes, an intraoral radiographic survey is really good if the patient has sort of just generalized oral disease, or they have potentially, a lot of dental treatment and they want to just get an overview of what's going on in the mouth generally. Intraoral imaging is really helpful. So when we're talking about an OPG, this is the equipment that we're talking about. So now in, I think, all hospitals, in Scotland at least, it would be a digital imaging machine, although I don't know that to be 100% true actually, so don't quote me on that, but I think most places have digital imaging. So obviously, the image is there immediately like it is with DR, so it's very, very quick. Images can all be stored and viewed and enhanced on the computer, so just exactly the same as all the benefits of DR are the same for a digital OPG machine. But obviously it's expensive when you first invest in it. But I would be surprised if most places didn't have digital OPG equipment, but please do correct me if I'm wrong. In terms of techniques, this is when it can be a bit tricky. We used to do these on pediatric patients, and it was always a total nightmare, like getting a 7-year-old to stand still while something rotates around their head. So yeah, they can be a wee bit tricky. And I think also for an adult, if you have someone who's maybe intoxicated or someone who's maybe not cooperating, they can sometimes be a bit of a nightmare. Quite often they can come in through like when you're on night shift because somebody's been punched in the face or whatever it might be. So sometimes they can be a bit tricky, but once you kind of get to know your machine and you practice quite a lot, you'll become more confident with them. Definitely something that I was quite nervous about doing when I first qualified, and I was working in Manchester, and they did come through the door late at night, and it was a kid, and I really did feel quite stressed about it. But hopefully you'll have good instructions on how to use the machine, and you'll have practiced and you'll feel quite confident. So even if you're out in your normal placements now and it's something that you're not that confident, now is the time to start saying, can you just run through the OPG machine with me, just so that I feel more confident when I qualify. So you've got the X-ray tube, and there will be a video for you to look at after this, because it'll be much more easy for you to visualise. But so essentially there's the X-ray tube and the cassette or the DR image receptor rotate around a pivot point, and then the detector rotates in the opposite direction, and then the objects within the image layer will appear sharp, okay? And then the objects that are front or behind will appear blurred. So you have this panoramic view which has a sort of narrow beam. Okay, so you can even pause this just now and just watch the video on GC Learn underneath this lecture, just so it's fresh in your head that you understand how the actual technique works. Okay, so in terms of positioning, you usually will have a triple laser beam on your machine, but it does depend on what machine you're using. You have to make sure that the patient doesn't have any jewellery, so make sure you take off sort of necklaces, earrings, glasses, any piercings that are going to cause an artefact, any false teeth, all have to come out. Usually you wouldn't use a thyroid collar, but that might differ depending on where you work, so I would just double check that with your site. And then you'd have the chin just slightly raised, sitting on the little ledge that's part of the machine. So you can see on the right hand side here the position for the OPG. So you want this mid-sagittal plane to be perpendicular to the floor and centering just right through the nose. And then you want your Frankfurt plane, which you can see at the bottom here, which basically is the plane that runs sort of from the lower orbital margin into the external auditory meatus, and you want that to be parallel to the floor. So these are your two planes that you're considering when you are positioning for OPG. And again, just practice, see if you can maybe practice on someone else. I'm presuming you're still allowed to do that with COVID restrictions and everything. So you can practice on someone else just so you can get the position right, so you feel a little bit more confident. So what can you see when you do an OPG? You can hopefully, if there is something to see, sometimes there's not, but you can see any callus lesions, any periapical pathology, any partially erupted teeth, so teeth that are about to come through that are maybe causing a lot of pain. You might see the presence of any crowns or implants, and it is the gold standard for trauma, so you might actually see that someone who's been punched in the face or someone who's been in a car accident or whatever it might be, you might see some fractures, some missing teeth, some broken teeth. So it is a really good method of just getting an overview of the mouth. So in terms of your anatomy, again, you can familiarise yourself with the anatomy, but we can go through it a little bit. So you can see number one there, that there's the premolars, and it's the upper left, because obviously it's the patient's left that we're talking about. And then you can see the upper incisor. Quite interesting there, you can see number 3 that this is an unerupted wisdom tooth, so still to come through. And then you can see that you've got like the pulp of the lower molar there, number 5. So you can see it gives you lots of information. You can also look at the bone, which is really interesting for us, obviously. So you can see number 3 there, you've got the temporomandibular joint, so where the mandible meets the temporal bone. you can see number one, you've got the coronoid process. So you can see that you can see the angle of mandible really well as well in number 5 there, and the alveolar ridge. So it is a really good overview of the mandible bone. And then this one gives quite a good overview of everything that you can see. So you can work your way through this and see if you can identify and practice, identifying these different anatomical landmarks. Essentially, you can see quite a lot. So over to the far right here, you can see the external auditory meatus, this little loosened hole. And as you work your way down, you can see the condyle of the mandible, the zygomatic bone sitting just behind it, the coronoid process. Because it's panoramic, you can see sort of a shadow of a hyoid bone on both sides. This little small hole in here is the foramen of the menti. Yeah, so there's lots of different things that you can identify from an OPG image, so you can see why it is quite helpful for clinicians. Sometimes the positions don't look too good, and I'm sure maybe you've seen this before, or you will have experience of this. I know I have, where you're positioning maybe just like when you position a knee or an elbow, it doesn't look quite right, so you need to go back and reposition the patient. Sometimes if the patient's chin is just a wee bit too high, then it can cause the OPG to look quite flat. It looks like there's a loss of sort of sharpness, and the condyles look quite splayed, so it almost kind of looks too straight basically when you're looking at it, so it doesn't look the way it should. And then sometimes when the patient's chin is too low, it has the opposite. So if the patient's chin is too far down, you can almost see why it looks this way. It looks like the patient is smiling, and it's too much of a smile. And basically the apices of the mandibular incisors will look all fuzzy. So you don't want the patient to look like they've got a really big sort of toothy, grinny smile, but you also don't want it to look like a straight line. Essentially what you want is something maybe like this, which just appears, sort of as an in-between, basically. So in terms of patient care, obviously you have to consider the usual ID, justification, LMP, all the things that we have to take into consideration, consent. These all still apply for dental radiography, so do all the regulations still apply. I think one of the most important things, especially when it comes to OPG, is just having really clear instructions, because it is quite a long time to hold still, especially if someone might not be steady on their feet, or it's a child, or maybe it's someone who is not taking direction well. Just be very mindful, you're going to have to step away to expose, and they're going to have to stand and hold on and not fall over. So just keep that in mind. You don't want to walk away and then they suddenly fall on their collapse or whatever it might be. So ensure the patient is stable. If they're not stable and you don't feel that they're able to do the x-ray, then obviously you'd have to speak to the referring clinician about that. You can still use lead, although I know that some sites are considering or reconsidering the use of lead, so just use it in line with your site's protocols. Ensure that the patient is comfortable. If they're not comfortable, chances are they're going to move. So you want to make sure that they're as comfortable as possible, which isn't always easy, especially if they've been punched in the mouth or they've had some sort of trauma to the mouth. It's not very comfortable asking them to stand and bite onto something, but for I think it's like 11 seconds or something like that. So it can be quite tricky for them to be comfortable, but you just want to try and make sure they're as comfortable as possible. You've given them all the information, you're telling them exactly what they have to do and that it's going to be over soon, just so that you can try and get the best image. But one of the main things is to tell them the images that the tube is going to move. So quite often people might forget to say that, and then the patient gets a fright because they're standing there, they're not expecting it to move around them, and as soon as it moves they jump, and then obviously the image won't be diagnostic. Again, it's really important to observe your patient, which you all know that anyway, and adhere to infection control. So obviously it was important before, but it's even more important now to make sure that you are wiping down that machine, changing the bite block, just adhering to strict infection control procedures as much as possible. So one little thing I just wanted to highlight for you. So it's not just sort of general radiography that gets used in dental radiography or dental imaging. Sometimes something called cone beam CT can be used, and that's if maybe the radiographs aren't, you know, diagnostic, or they're not sufficient, or they're maybe having some sort of really intricate surgery where they want 3D you know, formats or something like that. So they can use cone beam CT, which is essentially just a cone beam shaped X-ray beam that will move around the mouth. It is higher in terms of dose than, say, an X-ray, but lower than normal CT. And basically it'll provide really detailed, you can see on the image on the left hand side, really detailed images of the bone in the teeth, and it can be helpful for treatment or for surgical planning. So you might hear more and more about that. I think they are trying, I think I read a dissertation actually about how low dose cone beam CT is coming in to play. So we'll see how this pans out basically, but it does get used, and if you do get a chance to go to dental hospital, maybe you would see it there. It's not something I think you would see in other hospitals, but I could be wrong because I don't actually know that much about it, if I'm being honest. Okay, so that's us all finished. This was just to give you a brief overview of dental radiography. Please do go and watch the other video that I've posted up, and I'll see you at the tutorial. Okay, thanks very much. Bye.